Good morning. Our lecture today is to complete the previous lecture of the etiology of malocclusion. The fact that the lips and cheeks function outside and the tongue within the dental arches has led to the concept of a neutral zone existing between the inner and outer perimeters of the dental arches, where the forces of the lips and cheeks on one hand and the tongue on the other hand are balanced and within which the teeth are positioned. This zone should be considered not only in relation to muscles of forces but also in relation to intraoral air pressures which are induced by mandibular positions and movements, occlusal contacts, and periodontal ligament. It's important to keep the teeth in the neutral zone at the end of orthodontic treatment, otherwise they will move to take up other positions. The tongue. In the previous lecture, we talked about the lips as the soft tissues and the neuromuscular systems that affecting on the and considered to be as a general factors affecting on occlusal development. Nowadays, we are talking about the tongue. The tongue functioning in conjugation with the lips and cheeks in guiding the erupting teeth, and this is affected by its size, its resting posture, and its function. The size of the tongue is mainly related to the size of the lower jaw. If the lower jaw is larger than the upper jaw, the tongue is too large to fit within the upper arch. Therefore, tongue finds space between upper and lower arches and prevents full vertical development of the dentoalveolar structures, resulting in open bite, or to procline both upper and lower teeth, resulting in generalized spacing. The other factor is the resting position of the tongue. The tongue is ideally within the dental arches, following the space enclosed by the teeth. Sometimes the tongue takes up an adaptive postural position, slightly protruded between teeth to touch the lower lip, which will prevent the full vertical development of the incisal segment, resulting in incomplete overbite. This is produced seal the front of the mouth to allow nasal breathing, tongue lower lip anterior seal rather instead of lips oral seal, when there is difficulty to hold the lips together due to vertical or sagittal lip discrepancy. The function of the tongue. Is concerned with mastication, swallowing, and speech. Its effect on the dentition is mostly related to swallowing. After the food mastication is completed, the swallowing of food and fluid take place in a sequence as follows. First of all, there is closure of the lips and followed with teeth in light occlusal contact, tongue elevated to the palate, and finally there is a momentary clenching of the teeth as food passes into the pharynx. Variation of normal swallowing are also seen, which may be described as adaptive swallowing and swallowing with the endogenous tongue thrusting. In the adaptive swallowing, there is a positioning of the tongue between teeth during swallowing and may be carried out with the buccal teeth apart, tongue positioned between teeth. Reduce the muscle and air pressures within the upper arch, lead to narrow arch and buccal crossbite. Also, prevents the full vertical development of the anterior dentoalveolar segment, resulting in incomplete overbite, or buccal teeth together lead to incomplete overbite or anterior open bite due to forward position of the tongue. While swallowing with the endogenous tongue thrusting, the swallowing activity is accomplished by an anterior thrust of the tongue, which is a basic neuromuscular mechanism. Is sometimes associated with the anterior lisping during speech. It prevents the full vertical development of the anterior dentoalveolar segments, resulting in an incomplete overbite or anterior open bite. These two variations have somewhat similar effects on developing occlusion. However, they respond differently to orthodontic treatment designed to reposition the teeth. The adaptive tongue swallowing will be changed if the teeth are moved, but the endogenous tongue thrusting not, and will reproduce the original tooth position if these are altered. The third general factors that affecting on the occlusal development is the dental factors, and the teeth is the relationship between the size of the dentition and the size of the jaws. Ideally, there should be adequate space for teeth to erupt into the mouth without crowding or spacing. In primary dentition, the ideal situation exists when there is a spacing between the anterior teeth that will give better chance to permanent incisors to erupt without overlapping. The disproportion between teeth size and arch size can be either there is excessive dentition size in relation to dental arch size. As we see here, there is either overlapping and displacement when the dental arch is too small for the dentition or teeth too large for the dental arch or both. The teeth will be displaced. The most affected teeth are the last teeth in each group, either lateral incisors, second premolars, canines, and third molars. Or there will be an impaction of the teeth, occurs when eruption of the teeth is completely blocked by other teeth due to crowding. Also, it affects the last tooth in each segment. Mesial movement of the teeth either associated with alveolar growth as part of dentoalveolar forward development, also called mesial migration, or movement of individual tooth into space created by interproximal attrition, or loss of the teeth. This can occur any time during or after growth period. The other one is the excessive dental arch size in relation to dentition size. It is less common, occur when there are too small teeth in relation to the size of the dental arch, or too large dental arch in relation to the size of the dentition, or both, which will result in spacing. The size of the dental arch may not be the same as the size of the basal bone, because skeletal relationship and muscular factors can produce a dental arch which is larger or smaller than the basal bone. Therefore, dentition should be considered in relation to dental arch rather than jaw size. Now we will talk about the local factors affecting the occlusal development. The local factors including anomalies in the number of the teeth, either supernumerary teeth or missing teeth, anomalies of tooth size, anomalies of tooth shape, abnormal level of frenum, mucosal barriers, premature loss, prolonged relation, delayed eruption of permanent teeth, abnormal eruptive path, ankylosis, dental caries, improper dental restorations. The first anomaly that affecting the occlusal development and lead to malocclusion is the anomalies of the tooth number. There is either an increased number of teeth or supernumerary teeth. Each jaw is designed to hold only specific number of teeth at a particular age. The anomalies in the number of teeth can be of two types: the increased number of teeth or supernumerary teeth. The supernumerary teeth can vary remarkably in size, shape, and location. They may be supplemental teeth, which bear a close resembling to a particular group of teeth and erupt close to the original site of these teeth, incisors, premolars, or molars. As we see in this picture, there is supplemental teeth of lower premolars. The other type of supernumerary teeth is the mesodens, or the conical supernumerary teeth. It is the most commonly seen supernumerary tooth. It is usually conical in shape, with a short root and crown. Situated between maxillary central incisors and can vary considerably in shape. It can be seen erupted or impacted, singular or in pars. It can occur in the maxilla or in the mandible. The supernumerary teeth can cause either one of these malocclusions, which are non-eruption of adjacent teeth, or delay in the eruption of the adjacent teeth, deflect the eruption of the adjacent teeth into abnormal locations, and increase in the arch perimeter, increasing the overjet in the mandibular and maxillary arch, and also there would be a crowding in the dental arches. All these malocclusions could occur due to supernumerary teeth. The other anomaly of the tooth number is the less number of teeth or missing teeth. Congenitally missing teeth are more commonly seen in comparison to supernumerary teeth. It can be either anodontia, hypodontia, or oligodontia. The anodontia characterized by congenital absence of all primary or permanent teeth. It is divided into two subdivisions, either complete absence of teeth or partial absence of teeth. The hypodontia, there is usually missing one or two permanent teeth, while the oligodontia is the congenital absence of 6 or more teeth. The most commonly congenitally missing teeth are third molar followed by the maxillary lateral incisors. The second local factors affecting occlusal development is the anomalies of tooth size. It includes either macrodontia and microdontia, which can be localized or generalized. The true generalized macrodontia, where all the teeth are larger than normal and is seen in cases of pituitary gigantism. The true generalized form of microdontia, where all the teeth are small, is rarely seen. It's usually associated with cases of pituitary dwarfism. The most commonly seen localized microdontia involves the maxillary lateral incisors. The tooth is called peg-shaped lateral incisor and exhibits a peg-shaped crown with the mesial and distal sides converting incisally. The root may be shorter and more cylindrical than normally seen. Relative generalized microdontia may also be seen, but should be considered as an illusion of the true condition. The third factor that affecting occlusal development is the anomalies of the tooth shape. The common anomalies of tooth shape that leads to malocclusion include dilaceration, true fusion, gemination, concurrence, and talon cusp, dens and dent. The first one is the dilaceration. There is a sharp bend or curve in the root or the crown. It generally doesn't affect orthodontic treatment planning, but may complicate the extraction of the affected teeth. The second anomaly of tooth shape is the true fusion. It's seen when the tooth arises through the union of two normally separated tooth jambs. It might lead to spacing, or sometimes it might complicate its movement by orthodontic means. Fusion should be differentiated from gemination. Gemination, the anomalies of which arise from division of a single jamb by an invagination leading to the formation of two incomplete teeth. While concrescence refers to fusion of cementum of teeth which occurs after root formation has been completed. The talon cusp is an anomalous structure projecting lingually from the cingulum area of a maxillary or mandibular permanent teeth. Especially in the incisors, it might interfere in proper occlusion. its grinding invariably leads to pulpal exposure, necessitating root canal treatment. And finally, dens indent is used to denote a developmental variation which radiographically may resemble a tooth within a tooth. And thank you for your listening.